This program is brought to you by Emory University.
Good morning, everyone. It is my pleasure to introduce Dr. Olasimbo Chiadika to the group this morning. She is an assistant professor in the Division of Cardiology at McGovern Medical School at UT Health Houston. She's a graduate of Columbia University, where she completed her undergraduate medical school, cardiology fellowship, and advanced imaging training. She is the medical director of the outpatient cardiology clinics and also the co-director of quality initiatives in cardiology. She also serves on the board of the American Board of Internal Medicine Cardiovascular section. And appropriate to the topic she will be speaking to us today, she has a very special clinical interest in sickle cell related heart disease. So this morning, Dr. Chiadika will be talking to us about the cardiovascular effects of sickle cell disease. Dr. Chiadika?
Thank you so much, Dr. Isiadiso. Thank you so much for this opportunity to speak to you about a topic that's really dear to me, something that we don't really talk about a lot in cardiology. So it's really a privilege to speak with you today. All right, let's get started. All right, here we go. I have no relevant disclosures regarding this presentation. So my objectives today are to describe the pathophysiology and epidemiology of sickle cell disease, and to identify the manifestations, diagnosis, and prognostic significance of cardiac disease in this disease. We want to discuss the significant impact of pulmonary hypertension in sickle cell disease. So overview of my topic, we're going to cover a lot of ground this morning. I know it's early. We will go over the epidemiology of this of sickle cell disease. We would talk a lot about the pathophysiology, and we would mention some cardiac disorders of sickle cell disease as outlined, with a real emphasis on pulmonary hypertension, and I would say also diastolic dysfunction in this patients. And then we would just kind of like wrap up talking about some new sickle cell disease treatment that's out there that you may hear about, and just to make us a little bit more familiar with those medications. Okay, so sickle cell disease is an autosomal recessive single gene disorder. As this figure shows you, it basically entails hemoglobin S. It's formed because there's a substitute of T for A in a 6 codon of the beta globin gene. Because of that, you have a replacement of glutamic acid with valine, and so therefore, in the deoxygenated state, the hemoglobin S polymer tends to kind of like twist around. It tends to congeal, form polymers. That polymers that it forms in the hemoglobin is what leads to sickling and damage to the cell membrane of the red blood cells. Because of this, some sickle cells would adhere to the endothelial cells. This leads to vaso-occlusion, and therefore you can see that the pathophysiology of sickle cell disease is complex and involves erythrocyte sickling, acute vaso-occlusive events, hemolysis, endothelial vasculopathy, and chronic organ damage. The most common form of sickle cell disease is the homozygous hemoglobin SS inheritance. As I told you, replacement of glutamine with valine, and that actually occurs in almost about 3/4 of these patients. But there are other mutations. At times, there's a lack of production of one of the beta globin allele, as you will see in the thalassemias, and so you may have hemoglobin S with a beta. And hemoglobin SS genotype is really the one that is most associated with more severe hemolytic anemia and leads to the increased risk for cardiovascular complications. So let's go over some of that epidemiology. Sickle cell disease was first described more than a century ago. It affects 1 of every 365 African-American births in the US. 1 out of every 16,000 plus Hispanic American births are affected. So about approximately 2,000 babies are born with sickle cell anemia in the US every year. However, in Africa, over 200,000 babies are born each year with sickle cell disease. Over 25 million people are affected with sickle cell disease worldwide, and it tends to be more prevalent in parts of the world where malaria is endemic, like sub-Saharan Africa, India, Mediterranean, or Nigeria, where I'm from. And the reason why for this is it's thought that when the S mutation is linked with a C mutation, it actually protects against malaria. And so through that, there's been a preservation of this mutation in that area. So while in underdeveloped countries, the mortality of children born with sickle cell disease is still very high. As you can see, 50 to 90% of children born with sickle cell disease in Africa die before the age of 5. In developed countries, however, the survival rates have continued to improve. In 1994, the median survival for patients with the hemoglobin SS, thalassemia, and also the thalassemia gene was estimated at 42 to 48 years. But that's actually it's been getting gradually better. In 2001, a study done in Jamaica showed that survival had increased to 53 to 58 years. And in the United States, there was data showing a median survival of 58 years. That's in 2014. However, there was a UK study actually that looked even better in 2016, reported with in their population, they reported a survival up to 67 years. So this disease is certainly changing in developed countries. But nonetheless, the life expectancy of patients with sickle cell disease is still shortened by over 2 decades compared with the general population. In high income countries, the survival rate to adulthood is over 98%. What accounts for this improved survival is so many things. Now there's good vaccine therapy, antibiotics, improved screening, and management of acute complications have really helped a lot. So heart disease is a major factor of sickle cell deaths. The chronic progressive end organ damage with cardiac involvement has become the main cause of death, affecting about 20 to 32% of the patients. A study of 5,000 deaths in sickle cell patients over a 10-year span, this was CDC data, showed that most deaths occurred between the age of 30 and 50s, and mostly due to cardiac disease, about 32%, closely followed by respiratory complications and renal function and renal disease. Autopsy data of about 306 sickle cell patients showed that actually, even though they could not fully identify why these patients died, just looking at the autopsy data, but it was clear that there was a lot of cardiac involvement in this autopsy, with cardiomegaly being present in 58%, myocardial infarctions in 20%, heart failure in about 10%. All right, let's switch gears a little bit and talk about the pathophysiology of sickle cell disease. I feel that this is a core slide because essentially this is where it all starts. This is why we see what the syndromes that we see in sickle cell disease. And as we dive further on into the cardiac effects, we're going to refer to this discussion a lot. So the roles of hemoglobin S polymerization, hyperviscosity, vaso-occlusion, hemolysis, and endothelial dysfunction are shown here. Deoxygenation causes the hemoglobin S to polymerize, okay? And this leads to sickled erythrocytes as shown. And the sickled erythrocytes will now interact with leukocytes and the vascular endothelium. And eventually vaso-occlusion occurs. This vaso-occlusion leads to, as we see, infarction, hemolysis, and it also induces an inflammatory response. The inflammation enhances the expression of adhesion molecules, which further increase the tendency of these sickled erythrocytes to adhere to the vascular endothelium, and that even worsens the vaso-occlusion even more. Eventually, when there's reperfusion, as shown here, what happens with that is there's reperfusion of the ischemic tissue, and therefore this generates free radicals and oxidative damage. The damaged erythrocytes release hemoglobin, heme, into the plasma, and this actually induces a process where you now have nitric oxide deficiency, or what they call functional nitric oxide deficiency. Lack of nitric oxide in the vasculature, really not a good thing, because that actually is a trigger for the inflammatory process that leads to pulmonary hypertension, priapism, leg ulcers, and strokes. So you have two major underlying mechanisms happening here. We have a vaso-occlusion and hemolysis. The vaso-occlusion leads to ischemia and reperfusion injury. And the all marks of those are bone marrow infarction and acute chest syndrome. And the hemolysis induces vasculopathy, and then leading on to systemic and pulmonary hypertension, endothelial dysfunction, smooth muscle proliferation in the blood vessels, which is linked to the leg ulcers. All right, so if we kind of look at what happens with sickle cell disease, we can break it down to the acute syndromes and then the chronic. And the acute, as outlined, just different things. We know about the acute pain, infections, acute chest, but then there's this shift now to the chronic conditions in the lungs where you have pulmonary hypertension and more of a restrictive lung disease, and then the heart leading to diastolic dysfunction. We'll talk a lot about that. But of course, it's not isolated just to the lungs and to the heart, because of course it affects the kidneys, a huge source of morbidity for these patients, strokes, the liver, bones, and eyes. All right, let's talk about the hemodynamic effects of chronic anemia in sickle cell disease. So the chronic anemia actually induces increase in plasma volume to compensate for that. And that leads to increased stroke volume. The effects on heart rate usually tend to be neutral. There's decreased pulmonary vascular resistance and decreased systemic vascular resistance. This all adds up to leading to more of an increased cardiac output, kind of like stress on the heart. There's increased wall stress on the heart, and that induces compensatory hypertrophy and ventricular chamber dilatation. So this is shown schematically here. On the left, we see with the homozygous SS sickle cell disease, we have severe LV dilatation, eccentric hypertrophy, diastolic dysfunction, severe left atrial dilatation, high cardiac output, and pulmonary hypertension. In the SC disease, which tends to be milder, you have similar effects, but they can be much more diminished. And if you take care of these patients in any manner or form, you will see pretty much all of this at some point in their course. So let's talk more about that maladaptive cardiac remodeling, because really that's at the heart of it. What causes it? We have chronic volume overload, microvascular dysfunction, iron overload, systemic arterial hypertension, and kidney failure. We'll touch on the chronic volume overload first. So here's a study where they looked at, compared the left ventricular end diastolic diameter and posterior wall thickness in sickle cell patients, and they compared them to predicted normal values. This study was conducted in 1990 in 64 children. All those kids were less than 18 years. They all had sickle cell anemia, I think mostly SS. The echocardiographic data showed here that the LV end diastolic diameter was increased in 60% of the sickle cell disease children compared with predicted normals. And the LV thickness was increased in 20%, as shown in these curves. So in the same study, they showed that there's increased left ventricular mass and cardiac output in the sickle cell patients compared to normals. We see that the lower the hemoglobin, the higher the LV diastolic dimensions here, as shown here, and the higher the hemoglobin S levels in these children, the higher the LV dimensions. And that makes sense. The higher the hemoglobin S, the worse the anemia, we presume. So the severity of the left ventricular dilatation is closely linked to the degree of the anemia. Dilated left ventricle responds to the increased wall stress by developing an eccentric, more of an eccentric hypertrophy with that increase in the posterior wall thickness in relation to all the other walls. And the eccentric hypertrophy allows the ventricle initially to adapt to the volume, but trying to preserve the diastolic compliance of the heart, trying to maintain the normal filling pressures, but is maladaptive. So with the increase in LV mass, eventually you form diastolic dysfunction and impaired LV filling eventually results. Talking about this process of maladaptive cardiac remodeling in these patients, we move on to the process of microvascular dysfunction. So the chronic intravascular hemolysis leads to nitric oxide scavenging, like I showed in the earlier slide. This induces endothelial dysfunction, which with time can lead to myocardial fibrosis, a process that will promote diastolic dysfunction. So here in this cardiac MRI study, they really nice study. They use T1 imaging in cardiac MRI, which was used to assess the extracellular cell volume, extracellular volume fraction in these patients. So the more the extracellular volume fraction, that actually correlates well with more of a diffuse myocardial fibrosis. So looking at this graphs here, we look at the sickle cell patients compared to controls. We see that in the sickle cell patients, they had more of this extracellular volume compared to the controls. And when you compare them to all other disease, different kind of disease, using that same parameter, we see that really high evidence of diffuse myocardial fibrosis in these patients. Another cardiac MRI study published in Circulation in 2014. In this case, they use delayed gadolinium to get a sense of focal myocardial fibrosis. And as you see here, 25% of the sickle cell patients had evidence of late gadolinium enhancement compared to controls. And that would suggest areas of focal myocardial fibrosis. One surprise here in this study was that they were expecting to see increase in myocardial ion deposition in these patients, but actually that was not the case. As you can see, there was no difference in evidence of having myocardial ion deposition. And here's an image, same study, just showing focal areas of fibrosis in these patients. Moving right along to ion overload, as I alluded, ion cardiomyopathy is actually quite uncommon in sickle cell patients. They have it in their livers, very high incidence of that because of all the chronic transfusions, but not so much in the heart. Cardiac MRI studies have shown over and over again a low prevalence of about maybe 0 to 3%. So this is not really a huge driving factor in the effects on the heart. Let's mention systemic arterial hypertension and kidney failure in these patients. So normally, blood pressure of sickle cell patients are usually actually lower than age-matched normals. However, if they have high blood pressure, it tends to correlate very closely with incidence of increased risk of strokes, LV diastolic dysfunction, and death in sickle cell patients. The higher the blood pressure, the more you're gonna see these syndromes, even when the blood pressure is just mildly elevated over 130 over 80. So what you will consider hypertension in other, what you consider hypertension in sickle cell patients really needs to be in that lower value. And they do recommend that we treat blood pressure of over 140 over 90 in these patients. Renal failure is also quite common. A third of sickle cell patients will have some form of renal failure eventually, and that actually correlates with higher mortality. We have that vicious cycle, as we've seen also in many other syndromes of cardiac disease and renal disease in these patients. Okay, so now we move to the cardiac disorders of sickle cell disease. I laid them all out here. High output heart failure, left ventricular dysfunction, diastolic dysfunction, pulmonary hypertension, dysrhythmias, and sudden death. What I'm actually gonna do is I'm gonna log together the high output heart failure and LV dysfunction and diastolic dysfunction, really because they kind of just are related as syndromes of heart failure in these patients. So let's talk about heart failure in sickle cell disease. The symptoms are just like very similar to everybody else with heart failure. They have exercise intolerance, dyspnea, and fatigue. They can show signs of right-sided heart failure, jugular venous distension, hepatomegaly, peripheral edema. So you can see how it might be difficult to make this diagnosis in them because of their chronic anemia. Chronic anemia can lead to certainly the symptoms of that look like heart failure. That's why it's so important that the N-terminal pro-BNP be used readily in these patients to get a sense of if they're actually showing more signs of heart failure versus it's just their chronic anemia. Heart failure admissions are infrequent actually in sickle cell disease, but the incident rate is starting to rise. Why? Because of what I showed in my earlier slide. These patients are getting older. So as they get older, we're starting to see more heart failure in them. And in national inpatient data, they looked from 2005 to 2014, they found a total of 8,000 heart failure admissions of sickle cell patients. And they saw that the predictors of mortality were pulmonary hypertension, renal failure, and chronic liver disease. So what is the left ventricular ejection fraction like in sickle cell patients when you compare them to normals? This is a meta-analysis here that shows that the LV ejection fraction in homozygous S patients, we see that the prevalence of low ejection fraction, when we define it as less than 50%, is actually quite low, about 0 to 2.5%. And even in MRI studies, it's very, very low prevalence, about 0 to 4% will have an ejection fraction of less than 50%, okay? If a sickle cell patient has a low ejection fraction, you wanna consider alternative explanation, such as cardiomyopathy, maybe due to toxin, maybe due to alcohol. Definitely wanna do an MRI and other testing to look for secondary causes of cardiomyopathy because they tend to preserve their LV function. And I'm showing it to you in this MRI study published in the Journal of Cardiovascular MR in 2013. They look at 30 patients with sickle cell disease older than the age of 20. They compared them to age and sex matched normals. And we see here that when compared to these controls, patients with sickle cell disease had, yes, higher LV volumes, and they had decrease in ejection fraction, an increase in stroke volume and LVH. But if you look at that table really closely and look at the ejection fractions, you see that really this decrease is still within normal limits, definitely not below 50. So the ejection fraction in this cohort, a little bit lower in the sickle cell patient compared to controls, but still within normal limits. But the volumes are higher, the stroke volume is higher, the LV mass index is higher, as we've shown. And very, very interesting here is that you see here that there's actually lower right ventricular ejection fraction in sickle cell patients. You see that a 10-point drop. And then you have, of course, increased end systolic volume index correlating with the lower EFs, and drop in stroke volume index, and the mass index in the right ventricle is higher, okay? So you would see evidence of decreased right ventricular ejection fraction, quite common in sickle cell patients, even as this study shows, but the LV ejection fraction tends to be within normal limits. Of note in this study as well, they had 13% of the sickle cell patient had positive delayed enhancement on gadolinium, suggesting focal fibrosis. All right, so what are the causes of diastolic dysfunction in sickle cell patients? It's multifactorial. Due to the increased LV mass, due to the LV dilatation, the systemic vasculopathy, which leads to increased afterload with time, microvascular disease, high blood pressure, and iron deposition. Diastolic dysfunction is quite common in sickle cell disease. The number that's quoted is about 18% of adult sickle cell disease, but really it's very variable. It depends on the study that you're looking at and how diastolic dysfunction is measured in that study. And it can be very, as we all know, it can be very variable in interpretation. It can also be very variable based on age and other criteria. We know that when diastolic dysfunction is present in sickle cell patients is a marker of adverse outcomes, as I will show you shortly. And typically it's diagnosed with echocardiography using inflow velocities and tissue Doppler. But it can be, as we all know, it can be complicated. It can be difficult to interpret. There's so many confounders. However, even though it carries such a poor prognostic value, when you see diastolic dysfunction in sickle cell patients, it tends to be in the mild to moderate range, actually. Diastolic dysfunction is associated with increased blood pressure, older age, more severe anemia, and increasing creatinine in sickle cell patients. They did a study of 483 patients with sickle cell disease. They found that elevated E to E prime ratio, which indicates high LV filling pressures, was associated with all these parameters I just mentioned, but also higher BMI in this cohort. So role of echocardiography, I just always put this in because I don't know my audience and I figured I'll mention it just so we are all on the same page. The E wave measures the early diastolic velocity at the mitral annulus, okay, with a useful parameter because it's early feeling. The E prime is the tissue Doppler velocity of the lateral or and septal annulus. And the left atrial size is very helpful, though we'll talk about left atrial size in sickle cell patients shortly. And then the E to E prime over 15 is reflective of high filling pressures and corresponds with increased pulmonary wedge pressures of over 15, elevated left atrial pressure. And then the tricuspid regurgitation velocity is also quite helpful in determining diastolic dysfunction. So left atrial size in general, in the general population, we know there's been many studies that have shown that it's a marker, and left atrial dilatation is a marker for severity of diastolic dysfunction. It predicts cardiac events. However, left atrial size is not reliable predictor in sickle cell patients for reasons that I showed earlier. It's due to the confounders of anemia and volume overload. Everything is dilated in them. So we cannot use the left atrial size as a reliable indicator. There was a study done of 127 adult patients with SS disease. They showed the left atrial size was not associated with E to E prime ratio or with the diastolic function in these patients. So you cannot just use left atrial size. Now we know there's a linear relationship of hemoglobin level and LV filling pressures when we measure it with the E prime ratio of using the lateral annulus. In this study, it's called the Work Pulmonary Hypertension Study. It really was a study that was focused on treating pulmonary hypertension that you see in sickle cell patients with sildenafil. I will refer to the study a few other times. It was designed to be a large multi-center study, observational cohort, and they basically selected patients who had tricuspid regurgitant velocities, which I'll call that TRV from now on, of over 3 meters per second. And the whole point, the focus of that study was a sildenafil study, I said, but they also looked at different parameters in these patients. And they showed here that the lower the hemoglobin, the higher the LV filling pressures. So hemoglobin really correlates with LV filling pressures. Okay, diastolic dysfunction is an independent risk factor for death in sickle cell disease. Okay, so study of shown here, I'm showing you a study of 235 adult patients with documented sickle cell disease. They were all adults, and they were compared to age and gender matched controls. Most of these patients were African Americans with very few Hispanics. This is a very important slide because it's the heart of a lot of what we do with these patients. What they did was they measured different diastolic dysfunction parameters. The E to A ratio, we know when that's negative, it could correlate with diastolic dysfunction. A TR jet over or equal to 2.5. They did tissue Doppler. They look at the deceleration time of the E wave. And what is really important here is that when there was reversal of the E to A, you have a risk ratio of almost 5. So 5 times the risk in sickle cell patients when they have that as the evidence of diastolic dysfunction. And we can just go down the line when the TR jet is over 2.5, about 5 times, using the E wave, using E prime to A prime ratio. Okay, but I want to take you all the way down onto this table. When you log in 2 parameters, the E to A ratio that's negative and an increased TR jet, looking at both parameters together, you actually have 12 times the risk of death in sickle cell patients compared to patients who do not have that. So very strong markers of mortality in these patients. Looking at the same data in a different way, the Kaplan-Meier survival curves here. So if you call low risk the patients with low tricuspid regurgitant velocities and who have normal E to A ratio, and you compare them to those who have both of those parameters, look at that, a huge separation in survival right from the very beginning over time. So these are parameters that we really need to be aware of and be measuring in these patients. So there's a huge interplay of diastolic dysfunction and pulmonary hypertension, clearly an overlap. Anemia leads to diastolic left heart dysfunction, and hemolysis can cause pulmonary vascular pathological remodeling and narrowing, leading to pulmonary hypertension. So both diastolic dysfunction and pulmonary hypertension lead to decreased exercise capacity and increased risk of sudden death in these patients. So here's a study showing here that diastolic dysfunction and TRV are predictors of exercise capacity in this patient. So we see here in the graph here on the top that patients who had lower tricuspid regurgitant velocity, less than 2.7, okay, they are able to go further in a 6-minute walk distance compared to those who have elevated regurgitant velocities, okay, indicating pulmonary hypertension. And then if you look down here, looking at filling pressures compared to how far people can work, you can see that there's a negative correlation. The more the filling pressures, the less walking distance. So these are good predictors of how much exercise they can do. So how do we treat heart failure in sickle cell patients? Well, I think the same way you would treat them in everybody else. Loop diuretics, mineralocorticoid antagonist, except in a sickle cell patient, you definitely want to avoid dehydration, which is a trigger for crisis. So it can be very tricky. We want to inhibit the renin-angiotensin-aldosterone system. There's some evidence that it actually also helps to reduce the tricuspid regurgitant velocity. There's no clear evidence of antiplatelets preventing cardiac complications in sickle cell patients. And I probably should have included here, underlying all of this, obviously, is good treatment of the sickle cell, of the anemia, transfusing earlier than later, and really being on top of it, especially when they have heart failure. All right, so I'm moving on now to pulmonary hypertension. I did tell you that pulmonary hypertension is what I would call the big daddy in terms of what these patients really tackle. The prevalence of pulmonary hypertension in sickle cell disease is 6 to 10%. Is diagnosed as a mean pulmonary artery pressure of greater or equal to 25 millimeters mercury. There's been a recent definition revision of this that it can be defined as a mean arterial pressure, a pulmonary arterial pressure of over or equal to 20 with a pulmonary vascular resistance of equal to or greater than 3 Wood units, okay? The gold standard to measure this, as we all know, is the right heart catheterization. However, echocardiography is a valid estimate of systolic pulmonary arterial pressure. We do that by estimating the pressure from the tricuspid regurgitant velocity and adding the estimated right atrial pressure. Screening with echocardiography helps to identify patients that should be now examined definitely with right heart cath. So normal TRV will be less than 2.5 meters per second. Pulmonary hypertension is unlikely in these patients if the TRV is less or equal to 2.8, and they are not showing any other echo signs or clinical signs of pulmonary hypertension. There's no evidence of right-sided dilatation or no signs of right ventricular systolic dysfunction. However, if the TRV falls about 2.9 to 3.4 meters per second, pulmonary hypertension is quite possible, much more likely when it's over 3.4. I cannot talk about this topic without just mentioning the classification of pulmonary hypertension as defined by the groups. Group 1, 2, 3, 4, and 5. So group 1 would be pulmonary arterial hypertension. Group 2 would be more of a pulmonary venous hypertension from left heart disease typically. Group 3 will be those who have pulmonary hypertension due to lung disease or hypoxia. And group 4 patients will have chronic thromboembolic syndrome. And group 5 is supposed to be more of a mixed bag or unclear etiology. Well, guess what? That's exactly the group that sickle cell falls into. They fall in that group 5 because you can see every one of these things in sickle cell patients. So group 1, the pulmonary arterial hypertension, or what we call precapillary pulmonary hypertension, is when we have pulmonary hypertension, that's why we call it pulmonary hypertension, pulmonary arterial pressures of over or equal to 25, but you also have normal end diastolic pressures, okay, less or equal to 15, but the pulmonary vascular resistance is high, equal to or greater than 3 Wood units. In the group 2, which is more of pulmonary venous hypertension, or what we call post-capillary pulmonary hypertension, again, we have to have the elevated pulmonary arterial pressure over or equal to 25, but there's also increase in left ventricular filling pressures, evidence of increased wedge pressures, increased left ventricular end diastolic pressures, of greater than 15. So what is the pathophysiology of pulmonary hypertension in sickle cell disease? Well, I think earlier in my pathophysiology slide, I explained, we kind of talked about the role that decreased nitric oxide can play. And I'm just showing you here in this schematic here, okay, so the intravascular hemolysis releases heme, and that triggers this whole process where you have decreased nitric oxide bioactivity. That decreased nitric oxide bioactivity is really at the center of a vascular response, where an inflammatory response that leads to pulmonary hypertension. It affects the kidneys as well, the legs, and so forth. So we see here in this cross section, just what can happen to the vasculature, the pulmonary vasculature, where you have a very fibrotic, even sometimes thrombotic pulmonary bed as a result of this. There's a cross section showing you the intima. You see infiltration by smooth muscle cells. You can see proliferation of smooth cells in the media and even the adventitia, just from this whole decrease in nitric oxide that you see in sickle cell patients. And of course, we know that sickle cell patients can have thromboembolic events, that very common, that group 4, you could see more of a group 4 picture. Precapillary is possible with them, it's more arterial, or they just have, like I said, diastolic dysfunction and more of a post-capillary cause for their pulmonary hypertension. There is a strong, in case somebody is wondering, this has been shown that there's a strong correlation between the pulmonary artery systolic pressure as measured by echo and the right heart cath, okay? So shown here is a study where they just basically did, 2 patients, 96 patients, and they had echoes, and then they had right heart cath. And we see here a correlation of about 0.6 to 0.77, fairly good correlation of pulmonary arterial pressures and the right heart cath numbers in these patients. 50% of the sickle cell patients with TRV of greater or equal to 2.9 had pulmonary hypertension on right heart cath, okay? 15% of those with a TRV of 2.5 to 2.8 actually had pulmonary hypertension. If you now said, okay, well, since the yield is so low in that 2.5 to 2.8 range, I'm only gonna do right heart cath on those who have TRVs of greater than 2.9. Well, if we do that, then we're gonna miss the diagnosis in 4 out of 10 patients, okay? So we're not gonna make the, so therefore, those who have that 2.5 to 2.8 range, it's recommended that we use other parameters to assess if they truly have evidence of pulmonary hypertension. So it could be using the N-terminal pro-BNP or use their 6-month walk distance to have a sense of where they are. And if those two, if we use a pro-BNP of greater than 164 and a 6-minute walk test of less than 333 meters, then that has a positive predictive value of 62% with a false negative rate of 7%. So it's essential that we use other parameters in those patients who have in between numbers, as I'm saying here. So when the TRV is 2.5 to 2.8, then we want to look for other things. Do they have dyspnea on exertion, high BNP? Do they have evidence of right ventricular hypertrophy, decreased exercise capacity? If they do have that, on top of that, then the yield will be higher with right heart cath. So this is a key slide published by the American Thoracic Society that we use to screen these patients to kind of guide screening for pulmonary hypertension in sickle cell patients. So if the TRV is less than 2.5, you just continue routine screening. Routine screening will be about every 2 to 3 years with echo. And if it's in that 2.5 to 2.9 range, then you want to find out, are there other things that, like I just mentioned, if there are, that indicate pulmonary hypertension, they will go on to right heart cath. If on the other hand, there's really nothing else but just this mildly elevated TRV, what you want to do is, you just increase the frequency of screening. In my practice, I would usually do an echo in a year to reassess. If the TRV is over or equal to 3 meters per second, they go straight to right heart cath. So let's talk about that right heart cath group. So in that right heart cath group, if the mean arterial pressure is high, okay, now I know they have pulmonary hypertension, I'm going to classify them. But if the mean arterial pressure is low on right heart cath, they don't have pulmonary hypertension. So that's the gold standard. But they did have a elevated TRV when you did the echo. So you may want to increase your frequency. Again, in my practice, I would do it in a year, unless I have some clinical reason to do it a little bit earlier. Now, if they have elevated mean arterial pressure, mean pulmonary pressures on right heart cath, then they need to be classified to pre-capillary or post-capillary. If they're pre-capillary, it's more of a pulmonary vascular disease, so they need pulmonary arterial hypertension therapy. Okay, usually at that point in our practice, we would just engage our pulmonary hypertension specialists to help us as we treat those patients, oxygen being a key part of our therapy. And then if on the other hand, they look more like post-capillary, then they really need a whole bunch of workup. In fact, I like to say the post-capillary patients are really the cardiology patients, because now you're looking for reasons for left-sided heart disease in these patients. And you would do all this workup, PFTs, you want to get a ventricular perfusion scan, maybe they just have chronic thromboembolic issues, sleep study, looking for sleep apnea, and so on. Pulmonary hypertension in sickle cell patients carries a high mortality. In the NIH study, NIH pulmonary hypertension cohort study, they had 531 patients followed up for 4.4 years. 84 of them got right heart cath because pulmonary hypertension was suspected. 10% of those 531 patients were diagnosed with pulmonary hypertension. That's kind of one of the key studies where we got that 10% incidence of pulmonary hypertension is what you expect in sickle cell patients. And pulmonary hypertension was diagnosed in 39% if the TRV was greater or equal to 2.5, and 75% if the TRV was greater or equal to 3 meters per second, okay? So higher yield, the higher the TRV. 56% of those who were diagnosed with pulmonary hypertension actually had that pre-capillary pulmonary hypertension. In this cohort, 73 patients died during this follow-up. All-cause mortality in pulmonary hypertension patients was 37% versus 13% in 6 years, with a median survival for these patients of 6.8 years. What were the predictors of mortality in this study? It was, in summary, having elevated pulmonary artery systolic pressure, having elevated pulmonary pulse pressure, having a high transpulmonary gradient, having pulmonary vascular resistance, increased pulmonary vascular resistance, and doing poorly on a 6 minute walk distance. Here's a meta-analysis essentially showing multiple studies showing increased mortality. As you can see, all falling on the right side of unity here in this meta-analysis, even when the TRV was defined in the study as just over 2.5 in sickle cell patients who have elevated tricuspid regurgitant velocity, poor marker of higher mortality. And just briefly, I just wanted to make mention of what we've done in our center. We have a comprehensive sickle cell clinic here at UT Health, just a wonderful clinic for these patients where they just get all around care, all the different specialists in one place. And we've just been looking at our data. We reported our echo data in our patients. We saw a lot of similarities with what I've presented here. In our cohort, we actually had about 59% of them had increased TR velocities. We defined that as over 2.5, and just pretty much very similar data in a real life practice, community center. So how do we manage pulmonary hypertension in sickle cell patient? So we can break that down to the pre-capillary, post-capillary. So the pre-capillary pulmonary hypertension, you want to do a VQ scan, right? Ventricular perfusion scan, because if that's abnormal, they are committed to long-term anticoagulation if you have segmental defect. That is the test of choice, not a CT angiogram in these patients. Overnight polysomnography needs to be done because, again, quick rule out, they have sleep apnea, should be treated. And there's definitely a role for low flow oxygen if the pox-ox is less than 90%. We typically also will refer to pulmonary hypertension for consideration for endothelial receptor blockers or prostacyclin agents. but the first line will be oxygen if they meet the requirements. Every patient with pulmonary hypertension for sure, and maybe some people would argue every patient with sickle cell disease should be on hydroxyurea, and I will talk more about that. And then we should consider exchange blood transfusion. There's a small role for stem cell transplantation in this modern time, but the issue again is you need to have an HLA matched sibling, and the patient has to be able to undergo low intensity conditioning with chemotherapy. You have to wipe out the bone marrow first and they need to have an HLA matched sibling. So not a lot of patients will have that. For the post-capillary pulmonary hypertension, I referred to this as the cardiology pool here, because really you're looking for why would they have diastolic dysfunction? Why, how is the LV? Are there other causes? They really should have a cardiologist heavily involved, looking to make sure everything is optimized on the left side. What could be causing increased left filling pressures? Do they have maybe coronary disease? Do they have other things that needs to be done? Of course, hydroxyurea is key, and exchange blood transfusion is also a very good option in these patients. And of course, stem cell transplantation, as I mentioned as well. We're still talking about the cardiac disorders of sickle cell disease. We're getting to the end here. Dysrhythmias. So there's 38% prevalence of prolonged QT in children and adults with sickle cell disease. The QTC interval is increased in patients with elevated TRV and associated with increased mortality with a hazard ratio of about 8.3. Over 80% of sickle cell patients have arrhythmias when they're admitted and they're on telemetry. You're gonna see all kinds of arrhythmias, atrial tach, PVCs. They have a lot of arrhythmias. And autonomic nervous system abnormalities are actually quite common. We usually measure that with heart rate variability. They have very low heart rate variability, but we don't know the prognostic implication of that as of yet. Sudden death. Sudden death is common in sickle cell patients. Okay, so in autopsy series, they found that 41% actually die suddenly. In the NIH pulmonary hypertension registry, the study that I referenced earlier, 80% of deaths occurred either due to right heart failure or sudden cardiac death as the cause of death. There's a correlation, the correlation of arrhythmias to sudden death in these patients is really not fully known. We know they have a lot of arrhythmias, especially when they have crisis, but who is gonna end up having sudden death from those arrhythmias is yet to be determined. A huge area of research that really needs to be looked at. Okay, as I come to the end, I just feel like it will not be complete if I don't talk just mention some of the sickle cell treatment. Again, hydroxyurea, really approved in 1998, works well, it decreases crisis. It works by increasing fetal hemoglobin, but it does have side effects. The most common one that I see is ulcers, and they already have pain, they don't need ulcers. So sometimes it's hard to get them to take it. L-glutamine and DARI was FDA. So there was this huge gap, no other medicines, again, these patients are not really exactly a focal part of, they don't have ownership, right? So unfortunately, a huge span of years with nothing else having been developed to treat them. But then there's been a lot of activity lately, and DARI came out, FDA approved in 2018. It works by decreasing oxidative stress in erythrocytes. It decreases crisis, hospitalization. It decreases acute chest syndrome. Very promising. That's all we know for now. It's gonna take some time to see, maybe it can help with those end organ issues that we've talked about. And Velocitor or oxybutyr also came out in 2019, promising drug. It prevents polymerization of hemoglobin S by binding it to oxygen. So it increases hemoglobin. So again, we are still to determine how they will play. So my last slide, I know I went through a lot, but this is what I'm hoping everybody got out of this. I hope you realize that sickle cell disease, sickle cell related cardiac disease carries a high morbidity and mortality. Echo screening is important for diastolic dysfunction and pulmonary hypertension. It's crucial. We recommend increased use of other risk stratifying tools like pro-N-terminal BNP, 6-minute walk test, stress testing in these patients. The treatment of anemia is still the best treatment, right? If we can treat the anemia on time before there's end organ disease, that's optimal. So there's always a role for red blood exchange transfusion, especially the young patients. And hydroxyurea is key now in our management when they can tolerate it. There were other things that I didn't mention, bone marrow transplantation, stem cell, gene therapy. They're promising, but we're still to be determined. Lots of research in that area recently, especially. And then the new drugs. So thank you very much, and I'll stop there.
Thank you so much, Dr. Chiadika, for that very comprehensive summary of the cardiovascular effects of sickle cell disease. While I wait for some of the faculty to either submit their questions via chat or to raise their hand or unmute to ask a question, I was actually really surprised to learn that chronic anemia really doesn't have a significant, or at least is not responsible for a significant amount of heart failure admissions, and it only causes a small degree of actually LV systolic dysfunction when you compare them to people who do not have sickle cell disease. So that was really interesting.
Yes.
I guess I'll start with the first question. Since left atrial size is not a reliable factor for diagnosing diastolic dysfunction in sickle cell patients, has there been a shift towards using other modalities like strain imaging to accurately diagnose diastolic dysfunction in these patients?
Yeah, oh yeah, thanks for that question. Yes, so yes, there's been studies using strain imaging. I didn't mention it here. Actually, you know, strain indices are not really abnormal. Okay, in the studies that I've seen in these patients, they're not really abnormal. And I think that kind of correlates with the fact that the ejection fraction doesn't really change, I guess. But really, strain numbers are typically normal in these patients. We actually just started doing strain on our patients as well. And I'll be curious to kind of see what we see in our patients, like in a real life practice.
Absolutely. So we've got some questions coming in here. I'll start with this one from Dr. Winger. Is there a problem with iron overload with recurrent transfusions?
Yes, there is. So they have iron overload, and they tend to have a lot of iron deposition in the liver, but we don't see it in the heart. Like I showed there, cardiac MRI studies have shown over and over, we just don't see iron deposition in the heart for whatever reason. But yes, they tend to be on medications to lower their iron. The more transfusions they get, the more iron overloaded they get, but it affects the liver, but not the heart.
Excellent. Here's another question. As you mentioned, distal exertion can be very challenging sometimes because they have chronic anemia. If you send someone for a right heart cath and their resting PA pressures do not suggest pulmonary hypertension, at your center, do you then automatically pursue an exercise right heart cath?
We don't do exercise right heart caths, but it's interesting. Usually we will end there actually. If, I'm assuming, because I tend to I don't have a low threshold to send someone to right heart cath, especially because, as you may be aware, our patient population it's hard to get them to do stuff. It's hard to get them to follow up. So I would have done the exercise studies, maybe with echo, like a stress echo first. They would have gone through all of those things before they now go on to right heart cath. And so we don't really use exercise with cath, but if that was a question that it was something more exertional, I probably would have done a stress echo beforehand.
Okay. Is gene therapy an option for curing sickle cell disease?
Yeah. Yes. Gene therapy, if you've been reading the New York Times or anything, I mean, it's exciting. Gene therapy is curative for sickle cell. Basically, they deliver with virus. They deliver the genes to produce better hemoglobin. There's different ways to do it, or to decrease the production of hemoglobin S, and it works. But the problem with that is it comes with a lot of things. Patients have to get chemotherapy and have they have to be kind of wiped out so that they will receive the gene, right? So that's one issue. And then of course, accessibility to most patients is limited. And then of course, it's still in research mode, and there's some evidence that it actually leads to other cancers down the line. And of course, when you're trying to get consent for something like that, it's hard to kind of get that right patient that will match for gene therapy. So while gene therapy is curative for sickle cell, it's yet to be determined how we can apply that to our typical sickle cell population.
Dr. Smith, one of our faculty from the heart failure department has a question. I'll let you unmute, Dr. Smith.
There we go. Is there any evidence that the pulmonary hypertension, you were careful to mention that it's a marker of a poor prognosis. So I would assume these patients might also have other, maybe worse anemia, worse infarction in other tissues, those types of things. Is there any evidence that treating the pulmonary hypertension has a significant impact on prognosis?
Oh my, that's a very good question. I don't think so. I'll say to be determined, okay? Because we actually are enrolled, my center, in a study looking at the same thing, looking at the role of chronic transfusions on pulmonary hypertension, but also prognosis over time, okay? So we know that symptomatically they do better if you are transfusing them more frequently and getting the pulmonary hypertension under control, but it's not clear if that's going to improve mortality over time.
Just another question that I've kind of wondered about over the years in patients who had really severe anemia. The ACE inhibitors can inhibit angiotensin. Is there any real concern about use of ACE inhibitors in patients with severe hemolytic anemia who are requiring a lot of transfusions? Is there any reason to avoid those in treatment of their other issues?
If the renal function is good, if the renal if they don't have renal failure or end-stage renal disease, no, we can use ACE inhibitor in those patients as well. We do.
Thank you.
Mm-hmm.
Any other questions from our audience?
Thank you, Dr. Chiadika. Nice to see you on this platform. I think as a clinician, one of the things we always struggle with is right heart failure in patients with sickle cell disease. And there's this concept of preload dependent, but these patients present, although we heard recently that maybe we're being too cautious about preload dependence, but how do you manage clinically patients who are in active sickle cell crisis, who require IV fluids, but are also presenting at the same time with volume overload as a result of their acute and chronic right heart failure?
Yeah, that's really tricky, isn't it? Because you want to transfuse, obviously. That's going to be really important. Excuse me, that's going to be really important in treating the heart failure and kind of getting them out of crisis and even everything. So they need to be transfused, but at the same time, they're volume overloaded. So, as a heart failure doc, that would be really tricky because, yeah, they will be in the unit, they're getting diuresis or some form of way to get the fluid off, and at the same time, they need to get transfused. So it can be really tricky, yes.
We are right at 8:30. Any final questions for Dr. Chiadika? Seeing no questions, I will thank Dr. Chiadika for joining us and for presenting on this very interesting topic. Thank you so much from the faculty for your engagement, and I hope you all have a wonderful day.
Thank you.
Thank you, Dr. Chiadika.
The preceding program is copyrighted by Emory University.